Hello and welcome everybody to Lasers and Microscopes, the Perfect Marriage with Dr. Tom Larkin of Oral Systemic Mastery
Hi,
and the Larkin Protocol.
good
We
evening.
are going to allow maybe 2 minutes to let a couple of people trickle in. So we'll be starting in a couple of minutes here, but for now, as you guys get in and get settled, can you please put in the chat box where you are coming in from? So would love to see the chat. So please put in the chat. If you're driving, please don't, but if you can, please type it in and I'll let you guys know I'm in Scottsdale, Arizona. So would love to see where you guys are coming in from. And I'm just very excited to host Dr. Larkin tonight because I see microscopes as something to aspire to, something to work my way to as I get more comfortable as a hygienist with perio and time management and lasers. But I love Dr. Larkin's approach because he's saying, let's start the foundation with microscopes. Let's use this as a foundation to build the practice, build value, and build ultimate retention to the patient with the patient. So I'm very excited for his program because he is on the cutting edge of medical technology and how we're using that technology to better treat and serve our patients in a holistic way. So greatly appreciate you guys chiming in. See a couple of Q&As. Chat is disabled. Thank you. Let me fix that for you guys. Let me fix that. Okay. Everyone, attendees can chat with everyone. Okay, thank you guys so much for that. And I'm so grateful that you guys are typing into either the chat or the Q&A. Okay, there we go, Angie. Dr. Lau. Okay. Thank you, Kaylin. It's from Texas, North Carolina,
Oh,
Jenny in Florida, New Jersey. All right.
you know what?
Love it. Miss
Awesome.
Anna in Odessa. Thank you, guys. And as we're putting in the chat where we're coming from, who in here has a microscope in your practice already? Do we have any current microscope users? Hello, Dr. Pattern. Thank you for joining. Carla, thank you for being here. And some of you guys are from Dr. Larkin's community of advanced professionals. Thank you for being here. And some of you guys have taken my laser courses, and I'm so grateful to see you again. And as we continue to host these events, both live and in person, online, would love to kind of get your feedback and get reacquainted with you and see how you guys love it. So I will go ahead and let you take the floor, Dr. Larkin. Thank you so
Good.
much.
All right. I'm going to hit share screen and we're going to get right to it here. All right. Can you see that okay, Elaine?
Yes.
All right. This webinar is entitled The Perfect Marriage. What you didn't know is that I'm a marriage. No, not really. Okay. It was just kind of a cute title and I thought it was a little bit catchy. Okay. So the first thing that I want to look at is what do I mean by the perfect marriage? And I made this graphic and I thought that was kind of cute too. All right, so I always like to start a webinar with current events, okay? And one of the most current events that I know is that there's a new sheriff in town. And I think we all know that there's a new sheriff in town. And the new sheriff is, haha, I tricked you. It's Brett Kessler, the new president of the ADA, or the current president. And in June of 2024, the American Dental Association made a significant pivot in acknowledging the oral systemic connection. Now, I use the phrase better late than never. They seem a little late to the party, but that's okay, because in this announcement that they made, they use these bullet points: that the dentist will be recognized as a primary driver of health or disease. Dental medicine professionals will selectively eradicate pathogens while supporting healthy microbiome. And there'll be a collaboration between dentist and physician. This is all super duper positive. Okay. So even though I've been doing this a very long time, I see that as a positive. Now, in February of this year, very recently, the ADA comes out and says, we're going to have CDT codes for salivary testing. Okay. Now, once again, this is a procedural step forward. This doesn't ensure reimbursement. That's a whole nother topic, but it's a step. Okay. And I recognize steps. So this is last week. This is Dr. Tina Saw, and I talked to Tina yesterday. I've known her for a while, and she has developed a point of care. This is a chair side, just a preliminary screening test. But boy, the ADA has kind of endorsed it as a starting point, and a new CDT code for 2026. So I congratulate Tina and her hard work in enhancing this conversation about salivary diagnostics. Any conversation about this is a positive. So this is my most recent history. This is 10, 11 years ago. I'm course director at the University of Kentucky College of Dentistry. This is practice management. I've written 2 books on practice management. This is a long time ago. This is 10 years ago. And the strength of my practice was in hygiene. Hygiene is a 1/3 component of your business. I began using a microscope in 1989 and just did amazing things on the preventive side. So I kind of resurrected that in a more current form. Now, at this time, I left the university because I wanted to start doing startups and acquisitions, but with the wellness-based model, okay? Now, this is a practice. I didn't do the acquisition here. I came in shortly thereafter. But, just for comparison's sake, this is a hot mess, okay? This is a 30 or 40-year-old practice. Just so when you take on a practice like this, what you need to understand is that this is an immense task. This is a physical upgrade. This is a practice with probably 100% perio neglect. And so the first thing that I did in every practice was a microscope. And so they hired a hygienist, and we took this one patient at a time. Now, this right here, I don't recommend, because the amount of energy that it takes is immense. You really have to be on your game when you have patients that have been in a practice 10, 20, 30 years. No one's ever mentioned anything, but taking technology is how you have a chance at moving the needle, okay? So the good news is 6 years later, this is where that practice ended up, okay? So we built the foundational and got to the point where we could kind of move out of the dungeon, all right? So that's an acquisition. This is a scratch start, all right? Same time frame. This is a 6, 7-year-old practice, and this is easier to do, because when you put your stake in the ground and you start out with a microscope and a laser, and you're doing all these things, it's just an easier thing to do. Now, what was this practice able to accomplish in a very short time? Right there. I am so proud of Dr. Riley. Wait list only. New patients were closed to new patients, okay? This is the level of demand for the wellness center practice. I knew it inherently. That's why I left the university. And not to get too far off the track, but part of the motivation was Dr. Brad Bale, the Bale Don't Need method. I really felt compelled as a patient of his. I actually did a podcast with him this afternoon, and we revisited this whole thing about me leaving the university and really doing things to build practices kind of in his image. Okay. So this is what I stumbled upon. And I call this the patient saying yes twice. All right. So there's nothing more powerful than the phase contrast microscope chairside to create awareness and to educate the patient. Now, how much you want to use it with diagnostics, it's up to the individual provider, but just strictly awareness, nothing can compare. So what I found was that we put the microscope in first, started to build these advanced perio programs. And then the second thing that I wanted to do, and this is after a couple of years, I contacted the American Academy of Laser Dentistry. I hired a trainer to come in to do diode laser therapy certification for all of the hygienists and for all of the dentists, because I knew that therapeutically that the diode laser has advantages over just non-surgical perio. But what I wasn't prepared for was the fact that how easily the patient said yes, because lasers are not covered by insurance at all. It's an out-of-pocket expense. But what I found was that in the moment of awareness, when a patient is motivated, they see the bacteria, they go, oh my gosh, that's in my mouth. What are we going to do? And then the doctor or the hygienist explains, we're going to do periodontal therapy, which includes laser therapy. And laser has a connotation of being modern and whatever. But the patient, and then we explain to the patient, you know, that's not covered by insurance. The patient did not blink. They just said, let's do it, right? So what I saw there, that was where the concept of the marriage came up, is that the two things together were extremely powerful, because I overcame resistance from an education standpoint of, you have an infection, right? It is really difficult to explain to a patient, you have a 4 millimeter pocket, you have a 5 millimeter, you have a 6, you have bone. Patients they just don't comprehend that. When you go to the visual, oh, I get it. And then you have them motivated in the moment. And then you said, this is the therapy that we're going to do. That's the foundation of the concept of the marriage. It's a perfect marriage. So one of the things that I found out in the course of this is I asked the trainer, I said, so I don't know anything about, diode lasers. I said, what laser do you recommend? And she said, Beamer 980. I said, well, I don't know anything about that one. So tell me about it. She said, this is the only laser that I've traveled all over the country, that I can put in carry-on luggage. And I know that when I go to my next office, that it stays calibrated and it's not damaged. Okay. And I said, great, that's the one I want. I want the industrial strength laser. Well, it just so happened that Dr. Jim King, who is the owner of King Laser, and that's his laser. And Jim probably knows more technically about lasers and wavelengths than anything. So Jim's become a friend. He's become a faculty member for my course. And that's why that particular laser that we were using. Okay. So let's start at the most basic level. And this is understanding biofilm and infection. This is a shift from the traditional reactive way that we look at dentistry. Okay. And it starts with the salivary microbiome, where there's over 700 species of bacteria. There's about a dozen what we call pathogens and bacteria that we're concerned about. So on the left, you see what health looks like, and on the right, you see what dysbiosis looks like. Dysbiosis is a term that dentists are not familiar with. If you're a functional medicine doctor and you talk about gut health, dysbiosis is a very common term. We need to be comfortable in using that term, because that's what it is that we're diagnosing. So when you see here an area of subgingival pocketing and inflammation, that's anaerobic bacteria. Those are where the pathogens begin to grow. And so the shift from symbiotic, which is health, to dysbiotic is that whole process of disease. And so this is, with a microscope, what that looks like. And when I put that sample up on a 65-inch screen, I have the patient's undivided attention in 1 second. And the first thing that the patient says is, that's in my mouth? I had no idea that the film on my mouth was alive. And I say, absolutely, that's in your mouth. And this is actually very active, and this is actually very high risk. And then we begin the oral systemic conversations. And so tonight, I don't have the time to go into the depth of what that looks like, but what we're doing is that we're looking at a cursory level of how we take this information, okay? So let's talk about the business of dental hygiene. It's a one-third component of the average dental practice. but it's an absolute driver on the restorative end. That's the part that's unrecognized. So people, when they look at their KPIs and they're saying, I'm not making money or profit in hygiene, they do not understand how much of the restorative end of it, that the most important KPI in your practice is compliance in hygiene, okay? And there's been tons of research about it. So since I'm a root cause person, I have identified one of the number one problems in every dental practice in America. It's here. It's the distinction between a cleaning and periodontal therapy. This begins in dental school. In dental school, when we do prophies on people that bleed and have periodontal disease, this is incorrect. The minute a person bleeds, that becomes a periodontal patient. So we don't have a sharp, distinct line. That line is blurry. So then we graduate and we go into practice and we continue with this blurry line, and we let the insurance industry dictate to us what is periodontal therapy versus cleaning. We become kind of semi-lawyers where we submit information and beg for them to cover periodontal therapy, okay? The problem is we are submitting reactive information. We're submitting bone loss. We're submitting pocketing. That is after the damage has occurred. And once again, the line is blurry. Here is the line. It's health versus disease. And what you're able to do with a very inexpensive test with the phase contrast microscope is to decide, is this a healthy biofilm or is this dysbiotic? Okay. And that's the course of distinction. And that's where we direct patients accordingly. So is it a cleaning, or do we shift to salivary diagnostics, air polishing, ozone, and laser? Okay. And that's kind of the things that I do in my training, are the things within advanced periodontal therapy. Okay. So the Larkin protocol, which came up, I think this is 2020 where this name kind of came up, the early diagnosis and treatment of oral dysbiosis. Okay, that's what that is. And so I came up with this about 10 years ago. And the saying is test, teach, treat, repeat. And that's essentially what the Larkin protocol is. It starts with salivary testing. Okay. Now, I show you this slide because I've got a Facebook group, and this was posted last week. And this is, first off, it's beautiful photography, but it's really an example of what some of the people that I've trained have been able to accomplish. I look at these before photographs, and I know that in a lot of practices in America, they would be having an all on X conversation. I know that, okay? And so what I'm doing is I'm putting in a stake in the ground, and I talked to this doctor after she posted this, and I said, you know what? You're choosing teeth. You're choosing. So this was a process that this patient had to be taken through. Number one was awareness, education, and then they went through laser therapy and then look at that outcome. You know, those teeth are not beautiful by any stretch of the imagination, but that patient has a chance to have her teeth for the rest of her life. So under testing, this is a microbiologically based risk assessment model. This is different, okay? And you're seeing risk assessment, it's popping up everywhere, even though I've been doing this a very, very long time. So this is something that I said in a book that I wrote about 10 years ago. If we can test everyone biologically without any barriers to cost or comfort, there's no pain, we don't charge, and then utilize more sophisticated testing incrementally when indicated, we're optimizing the opportunity of patients to obtain the knowledge that enables them to make healthier choices. You have to understand this concept of enabling people to make healthier choices is based in education, both on the medical side and on the dental side. So we're enabling them to make better choices. So testing provides data that's used in all aspects of decision making. Now, I'm including salivary testing, PCR, genomic testing, and we adjust our preventive protocols accordingly. We use the test as an analysis of trends. Is the patient getting better? Are they staying the same? Or are they getting worse? So this is a friend of mine, Craig Bax. who's a faculty member too in the Bale-Donine method stuff. And these are some of the quotations that that he uses that I really, really like. And one of them is, and now that I have your attention. And when I put the slide up, that's a perfect example of, and now I have your attention. And then he talks about testing. He teaches carotid ultrasound. And Elaine was at my last course and she got to kind of see that firsthand. So what testing is a series of nudges, okay? And a nudge is a small push. And the concept of trending in the right direction. So I really like the way he thinks. A collection of small interventions that are designed subtly to influence decision. We all want our patients to choose health. We all want them to. But it's how we set the table educationally as to whether or not we're successful, okay? Now, a trend in the right direction. Something is improving and progressing toward a desired outcome. The problem that I see in salivary testing, not in the microscope, but in the more advanced testing, is that dentists are used to like black and white decisions. They want to do a test, and if the test is positive, they want to do a treatment, and then the test comes back 0 or negative. That's not how testing works. And so I want people to understand that sometimes it takes 3 months, sometimes 6 months. Everyone's different. That is the whole concept of personalized care, right? So this is the concept of quick win. And this is also where I classify the microscope as being completely unique. So you're a dentist and you want to change the trajectory of your practice and you are the leader of the practice. Well, it's really important. This is an article in Inc. magazine that says, establishing quick wins is critical for successfully leading change. All right. This is a really, really important concept. And here's why. You can say to your team members, you know, I'm wanting to go in this direction. But if it gets to be too protracted, people lose interest and they fall away and there's no buy-in. Okay. So the concept of the quick win is it gives the team something tangible. They can put their hands on it immediately. It gets them energized. It gets them motivated. It validates this is the new way that we're going to do things and the near-term strategic achievable goals. Okay. So now let me give you, this is an office and this is what really drives me on a daily basis. I trained this office last month. The doctor is super excited. He takes a short video the day after we trained and he sends it to me. All right. That right there is a stone cold quick win. All right. That was the team playing, you know, they were sampling each other and you saw the reaction. Okay. They're having fun, they're engaged. It's cool, you know, can't wait to do this clinically. That's a quick win. Okay. And the doctor then, you know, the reason why he sent me that video the next day, he was so thrilled at the buy-in because the greatest fear that a dentist has is to have an idea or have somewhere that he wants to go and he doesn't have, or they don't have the buy-in. Okay. These are Dr. Cialdini's principles of influencing behavior. Dr. Chris Phelps is a friend of mine, a faculty member. He's the only certified trainer. I use these things also in influencing behavior, the Cialdini principles. Now, the last part is facilitative learning. Okay. If you have gone anywhere and had any medical records done, blood tests or whatever, you've probably gotten them in this fashion, meaning this is a risk assessment delivery, meaning you get your blood test back from Quest or Cleveland Clinic, and if you're in range, it's green. If it's out of range, it's red. This started about 10 or 15 years ago. I saw a TED talk on the individual who said, we need to change our medical records so that people become more engaged. And after I saw that TED talk, I went back and I created this for my students. And it's an oral exam summary with the risk assessment model. So when you come in, what I'm interested in knowing is your risk level for caries, perio, and sleep. Okay. And then this says, what does that mean? And what can you do? Okay. This is a way of communicating with our patients. All of these are meant to help a patient choose better health. Okay. So under salivary diagnostics, we have phase contrast microscopy, PCR, and genomic. This is a custom configured. I've worked with a like a distributor to make this specific to my specifications. The first thing you see is one objective. Most microscopes have 4. So this is for screening biofilms. What I was able to do by removing all these extra objectives, I removed the eyepieces. I brought the cost down substantially in a laboratory grade microscope, but this only does the screening that I wanted to do, right? This is a high definition camera. It's kind of short and squatty, and it fits on any countertop. This is the world of salivary testing, which is kind of a confusing world, and we're not going to go into great depth here. I could do an entire webinar on this alone, but where I personally see this fitting, and once again, this is a marriage with the microscope. If someone is medically compromised in any way, shape, or form, insulin-dependent diabetic, history of heart disease, especially family history of dementia, then I say to that patient, you know, Mrs. Smith, I'm looking at your microscope slide. It's kind of crazy active, lots of stuff going on. I would be more comfortable if we do a salivary test. I need to know exactly what bacteria those are because I don't know with the microscope what those are. Okay. So that's the bridge to that. This is another salivary test. So if you looked on the CDT codes, there's now a test for this. This is a chairside test that you can look at, you know, and saliva is important. pH is important. Buffering capacity is important. This is a really simple chairside test that can be done also. So teaching, it's visual based. That's the first step of test. This is the second step, test, teach, treat, repeat. Visually based. That's why the video microscope is so compelling. It enhances comprehension, memory retention, engagement, and faster absorption. There's the microscope. There it is on a 65-inch screen. And, you know, if you don't get that, something's wrong. Now, this is called the Epiphany Bridge. Russell Brunson is a smart guy. He's written some very, very good marketing books. So this falls under the category of air polishing, which is another area of training that I do. And what it is the combination of showing on the screen the bacteria, then disclosing the patient and having them hold the mirror. Okay. So what I tell the patient is, do you see those bacteria on the screen? Now I want you to look at these areas on your teeth that are dark purple, pink, and teal covered, right? That's the bacteria on your teeth. These are the areas that you're missing in your daily home care. So what we're talking about is a really, really comprehensive way of clinical care, biofilm disruption, but also getting them doing home care that's meaningful. Now, this is from Dr. Bob Barkley in 1960. Barkley was a real pioneer in prevention, and he had a dedicated area in his office for conversations about soft drinks and different things like this. So this was my version of Barkley's, and it's a separate clinical area, non-clinical area, where you see the sugar in the soft drinks, sugar in the cereals, microscope, screen, and then this is where you can kind of sit down with somebody informally and have a conversation about stuff, right? This is giantmicrobes.com. You can get stuffed animals, and it's great conversation with the kids. You know, we screen kids. Okay, you would be shocked at the biofilm on kids. You know, it's a great opportunity to teach there. I'm not going into depth on home care, but some of the most important parts are obviously tongue scraping is just absolutely essential in a more comprehensive home care. Um, pH is important. Look at the products that you're recommending and be especially conscious of pH. It's a really important factor. Irrigation is important. This is a new ozone water pick. I love the carry-free products and different stuff. This is something kind of new. And this is something that I've experienced personally. I've done it twice, but for some reason, the second time, it just made sense to me. So about 10 years ago, I started training hygienists to have this conversation. The top of the chart here is the acid attack, which happens when you drink a soft drink. And we all know that the worst habit that you can have with a soft drink is to be drinking it over and over and sipping all day. But what I wanted the hygienist to tell the patient is, do you realize that every time you do that, you're creating an insulin response curve. You're creating a challenge to your pancreas. And essentially what you're doing is you're depleting and you're wearing out your pancreas. You're going to become insulin resistant, pre-diabetic, and probably diabetic by the time you're 30 by sitting there with Mountain Dew and drinking this all day, going boom, 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 right? So by addressing this and saying, listen, I can't take your soft drink away. I'm not stupid enough to think I can convince you to do that. But here's what I want you to do. I want you to drink that soft drink down in its entirety at one sitting, and then maybe follow it up with some xylitol calm. And I want to kind of neutralize some of that acidic effect. And I want to flatten. This is where this glucose monitor comes in. So what I did this for about a month, and this is the range. And what I realized recently is that this is a wearable, it's a trackable. And if we could get patients, now, if I'm not in clinical practice right now, I would be having patients with CGM monitors in the dental practice, okay? It's an incredible tool because if you flatten this curve, what you're doing to the oral microbiome is you're flattening that curve too. The same carbohydrate that create the oral challenges are trackable on this device. And I think this is the future, and I'm going to be talking a lot more about it. Okay. So under treatment, anti-infective approaches, air polishing, laser, and ozone. And so this is air polishing, and I'm sure you're familiar with this. This is with erythritol powder. This is small particle size. This is different than the old Prophy Jet. Now we can shoot up under the gum line, okay, which you could not do before with the Prophy Jet. And there's Elaine doing a beautiful laser procedure. And then this is aqueous ozone water, which is a great antimicrobial. I just did a podcast with the CEO of BioSure. And once again, beyond the scope of tonight, but it's a part of what my teaching protocol is. And then the last part is repeat. And so back in 1989, when I learned this from Dr. Paul Kais, it was called modulated microbiological periodontal therapy. And that was a brochure from way back when. And that was my monitor, which was a 13-inch monitor. So this is a slide of health. And what he meant by modulated therapy is that your recare, when you have people back, is dependent on this. It's not 6 weeks, it's not 3 months, it's not 6 months. It's until the microbiome quiets down, okay? That's how you determine a recare interval. Right there, you see some scattered strep, very low motility. That is a perfectly healthy slide. That's an objective for us if we're using the microscope, okay? So I have one more slide here, and I want to make a comment, and then I'm going to kind of turn it over to Elaine. And this is from another presentation that I've done. I have a whole series on a creation of value in hygiene. So years ago, I was sent this picture on the right. This is a local veterinarian, and I had lunch with somebody, and they sent me this picture with a very enthusiastic message that that their dogs had a cleaning, but also laser therapy to the tune of $800. Okay. And this person was not upset at all. They were absolutely thrilled that their veterinarian, this young lady, cared so much And the veterinarians have been having an oral systemic conversation for as long as I can remember. When you take your pet, they're going to tell you that your pet's lifespan is going to increase by 20 to 30% with a healthy mouth. And I'm sitting here saying, I don't know any dentist that's having that conversation. Any dentist that has the courage, or hygienist has the courage to say, you know what? If your gums don't bleed, do you know you're going to live longer? And really, the conversation today is not lifespan. I don't really care about lifespan. It's health span. Okay. It's how long we can stay healthy and vital. So let's really up our game here. And the opportunities there, like none other. I cannot tell you, I've been doing this a long time. I've never been busier than I have been right now for a variety of reasons. Our healthcare system is broken. I've known it a long time. And the solutions are in prevention. And there are things happening politically where prevention is going to be it's going to be mandated. So it's a good time to be in healthcare. And that's my presentation. Elaine. Oops, can't hear you.
Thank you so much. That was so great. Before I move in and kind of wrap it up, I would love to hear some feedback. I want to check the chat and I want to run you through, Doc, a couple of questions that have been coming through the chats. So Heather asked, do you incorporate oral probiotics in your treatment recommendations?
Yeah, and so we're probiotics, both pre and probiotics. And once again, that's a deeper conversation. But the concept of probiotics is this, okay? And that's a great question because it also has to do with the timing. The concept of especially with Probiora is one of the first probiotics. It's an oral probiotic. The concept is after pathogens have been reduced, and that specific one is for dental caries. Then when the probiotic is introduced, the synthetic strep become a placeholder and they prevent the pathogenic strep to come back. Okay. So that's an important concept to use. But probiotics are really important. And prebiotics are a new category. And Dr. Emily Stein is one of my faculty members that has a prebiotic that she's introduced. And what a prebiotic does, it interferes, her particular one interferes with the metabolism of pathogens, which selectively pushes them, suppresses them. Okay. So that's really the future. There's a lot of things that are happening, and probiotics and prebiotics are an absolute part of periodontal therapy.
Amazing, Doc. Thank you. We have another question. Where do you take the sample from? Anywhere in the mouth, or do you look for plaque first?
Yeah, perfect. No, and so it's subgingival. It's a great question. It's subgingival. My preferred area is a distal lingual of a terminal molar because that's an area that most people miss. But the objective is not to get a bunch of plaque, because if you put a bunch of plaque on a slide, the slide will actually be obscured. So what you're wanting to do is to go into the depth of the pocket, the apical 1/3 of the pocket with a sweeping motion, and to pull up. So the sample that you might get that you're placed on the slide could be the head of a pin, almost imperceptible to your vision, but it's still representative of the bacteria that we're looking at. Now, on a new patient, I will sample several areas, and I call that a pooled sample, POOLED. It's pooled together because what I'm looking at is the microbiome in general, right? You can take, like, let's say that a patient had an isolated 6 or 7 millimeter pocket with bone loss. You could take a sample, an isolated sample, if you wanted to see selectively what that looked like. But in general, we take pooled samples.
Excellent. And another question, how long does this entire process take? And I think that's a good one because I think that's the biggest question when a hygienist is already strapped for time and we're wanting to add more things to do in
Yep.
that, hygiene 40 minutes, 50 minutes, or 1 hour.
The best question at all. And I'm so thankful somebody asked that question because I, first off, I've been doing it. I've trained hundreds of people. I make this promise because it's the number one hygienist when anything is introduced into their workflow, it's like, whoa, 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 I can't do anything more. And my promise is this. My promise is this will save you time because what it saves you and what you find out almost instantaneously when you get that patient engaged immediately, you no longer have any conversations. You do not talk about pockets. Now, the charting you do for medical legal reasons. And once again, I'm not going to talk about 3 millimeter pockets that are diseased because that's a longer conversation. But you don't talk about bone loss. You don't talk about pockets. That's a tortuous conversation. Okay. And people look at you like, what? When you see that this test takes 90 seconds to maybe 2 minutes from the time you prepare it, put it on the slide and put it on the screen, and the patient's like, wow. And you go, and so it's either infection or no infection, okay? And the conversation just accelerates from there. So it saves time, and I stand by it, and no one has ever said, Dr. Larkin, you've wasted my time or you're making this more difficult. Once a hygienist uses a microscope, they'll never go back because it becomes almost a crutch. It's so powerful.
Excellent. And we have Ishmael say, we've been using the microscope with great results. Just started in December. How should we recheck perio pockets?
So you're going to check a patient at every exam. Okay. So since there's not a cost barrier, it's a 25-cent test. You're checking patients to see how they're doing. Okay. Because here's the thing about the oral microbiome. This is a really important concept that's kind of Dr. Stein kind of reemphasized this to me. It's dynamic. Okay. You don't cure gum disease. Okay. Because there's a whole host of factors. You have the immune response. You have all these, what I call bad things on the outside, trying to get on the inside. The mouth is the largest portal entrance of all kinds of stuff. Okay. So, and then you have the conversation about horizontal transmission. You can acquire this. You can start dating someone new. You got a brand new oral microbiome, and it may not be a good one. Okay. So, there's all kinds of factors that include that. So you monitor every time, after treatment, and hopefully you're going to achieve stability. But let's say you had somebody back for a 3-month or 6-month recare and they relapse. They may have just been sick. Their immune system could have been compromised. There's a whole series of factors. So that's why this is a nice tool. The salivary testing at $150, $200 out of pocket, it becomes very difficult to do that as a monitoring at every time. And what the microscope does too is it helps with the timing of when you want to do a follow-up salivary test. Obviously, with the microscope, if the microscope has a crazy field, I'm not going to do a salivary test necessarily at that visit because I know it's coming back positive. I just don't know how bad it is.
Excellent. Do we have any other questions? I would love for you guys to take the time right now and pick Dr. Larkin's brain while you have him here with us. Do we have anybody else? Okay. I'm going to go ahead and share my screen then. Let's see, view. Give me just 1 second, ladies and gentlemen.
Go ahead. I'll answer that question about the ozone water.
Okay.
So ozone water kind of becomes a standard of care, meaning hygiene bottles use ozone water. It's used for irrigation. It's used in the Cavitron. It's used everywhere, right? So it's not selectively used. And once again, that's a longer conversation with BioSure that has a dispensing device. You can get it right out of the tap. You don't have to make it with an ozone generator. So another conversation. Okay.
Excellent. So thank you again, Dr. Larkin, for joining us tonight and for really providing this wealth of knowledge that you have, really showing us the opportunity to bring microscopes to the practice. And if everybody can make sure, of course, I have to come in with the housekeeping things. Can everybody please make sure that they sign in? I did put the link in the chat, but if you want to receive CEs tonight and slides from my side of the deck, please sign in and we'll make sure that we get those to you. So really playing off of what Dr. Larkin was saying, why lasers? Why the perfect marriage? And how are we operationalizing what we are doing when we combine those two technologies? So just very briefly about me, I have been working as a laser trainer since right around 2014 is when I first started training laser. And it was all good and well to uh, get started on providing certification, but it was something very new. And what I saw very soon and quickly was a lot of people were not ready for laser. They were not ready to have these fee-for-service conversations that Dr. Larkin mentioned. Lasers are not covered by insurance, and a lot of dental practices really rely on that insurance reimbursement piece when they're dealing with patient care. And so naturally, we've had to evolve past relying on insurance, patients relying on getting that rebate and being able to fully pay out of pocket. So where I become very interested in working with clinical educators like Dr. Larkin, who are very passionate about up leveling the dental hygiene profession, really respecting what we do and what we can do for the practice. And B, really being able to help bridge that gap in education and understand how the using diagnostic testing and really getting that confirmation that, hey, there is bacteria in that mouth. You can see it right on that slide. That really feeds the case acceptance into using your laser technology. So as a clinical educator, these are the kinds of inquiries and conversations that I'm having with dentists, owners, providers, and this is actually an office manager that reached out. So I just took a quick screenshot of the voicemail that she sent me. So the key takeaways from her voicemail are, does the laser really help? And that's a valid question because how many of us in here, and only a couple of you answered that you already have microscopes in the practice. But how many of us are wondering, can I afford to bring this into the practice? What's the cost of yet another piece of equipment? And will my team actually use it? Okay, so how many times do we buy new technology, new toys, new materials for the practice, and it really just gets put by the wayside after all of the fanfare and excitement wears off? So does the laser really help? I really appreciate them asking that question, and this is why we have a study club, and I want to answer that question tonight for you guys. Now, do we have statistics on the laser? So this is such an honest question, but what statistics would help you understand laser more? And by the way, what laser are you talking about? I had a question in the chat saying, what is the best laser to buy? Well, the best laser to buy is the one that you're going to use for already the procedures that you're doing in your practice. And the next thing to say to that is buy the one that you can afford. We don't want to break the bank and get a laser in every single hygiene room when hygiene is not invested, dedicated, and really excited about using it. Next one I always see is our periodontist. Our periodontist does not use it. And that's really just alarming because we look to periodontists as the subject matter experts in periodontics. And the truth of the matter is there's a lot of politics behind cutting edge modality and traditional ways of treating periodontal disease. So it really pulls us to seek higher education and more in-depth knowledge on these subjects, on the technology, so we understand what it's doing. And also, it may in turn mean that once we do decide to start bringing these technologies into the practice, seeking referral network with other like-minded providers like myself, like Dr. Larkin. And Dr. Larkin knows several specialists all across the country that are already using microscopes, using lasers and so forth, and as do I. And then lastly, and this is one of my favorites, our hygienist was told in school that laser doesn't help. That really just breaks my heart. And it does go back to the politics. It takes a lot of effort, money, CODA accreditation to bring in new subject matter into a curriculum. And I'll be honest, I'm not a big fan of hygiene schools teaching lasers only because I feel like I was already 2 years into postgraduate into clinical hygiene, and I was still struggling to learn laser. You guys see that I studied laser for almost like the first 3 years, attending course after course after course, working with a mentor, Heidi Christopher, or Dental Team Advanced. She's actually in this program tonight, and she does do laser certifications as well in the upper Northern California region. Hello, Heidi. Grateful for you to be here tonight. And I'm not a big fan of teaching new grads or teaching not graduated hygienists that have been around the perio block, that know how to go back and forth with a patient who is very skeptical, very resistant to treatment. And we've all had those patients who just cannot believe that they need to have a deep cleaning or cannot believe that they have a disease. And it's a very, very sensitive conversation. And it's one that I feel that bringing in the technology really helps to help the patient understand. I think that's a good point that Dr. Larkin made in his piece. Help the patient understand what is going on with their body. And so when we start to ask why lasers, what piece does laser have in the matter? It really begins with understanding what the laser can do as a tool, but also as a medicine. So when we look at the body is comprised of water, bacteria, soft tissues. So when we look at what does laser do to help treat therapeutically, we want to understand that certain lasers are attracted to certain inflammatory mechanisms of the body. So when we start looking at how does laser work, how is it effective, how is it relevant, laser works to treat inflammatory process in the body. And usually we look at the key cell in diode laser or therapeutic laser that is most popular in periodontal therapy as the key cell that the laser is attracted to. So melanocytes or melanin is what gives me my dark hair color, my dark skin color. But what's interesting about the melanocyte is it also becomes active in states of disease. So think melanoma. Melanoma is a very aggressive skin cancer, which is characterized by blue, purple, brown patches of skin or patches of melanin accumulation in the skin tissue. So when we have looking at the next key cell that laser is attracted to stimulate immunity and help fight inflammation is the red blood cell. So taking us all the way back to not only the microbiology that Dr. Larkin is bringing us to, but also the immunology and the histology. If we remember, what is the key function of a red blood cell? It stimulates oxygen and it stimulates blood flow. We thrive on oxygen. So the second key effective benefit of using a soft tissue laser for therapeutic benefit is its ability to stimulate oxygenation within the tissue. You'll also learn in a certification course where we heavily go into physics, and the science behind it is understanding that a lot of the swelling and inflammation you see in the gingival tissue is water. It's crevicular tissue that's ridden and loaded with infectious bacteria. So to be able to say that you're confirming presence of specific pathogenic bacteria by utilizing a microscope, and now confirming that you're able to utilize a therapeutic medicinal laser to help treat those very problems is ideal. So I encourage you guys, if you're not already certified, or if you're interested to learn more, continue to come to these study clubs because I want to help make this information more accessible. It can be very intimidating to try to understand laser. So as this slide shows, there's several different metabolic processes that are happening when you use a diode laser in the tissue like you see here. That light, that energy, it's absorbing in the gums and it's stimulating those three key mechanisms to help turn down that inflammation, help relieve the patient of pain and inflammation, and help to stimulate the healing process. And that's the key. How are we stimulating the healing process besides just pumping, a scaler and hand instrumentation, which by the way is still the number one way to treat disease. We still want to use traditional instrumentation, but what other adjuncts are we using to help with that healing process? So I'd love to see in the chat, what adjuncts are you guys using currently right now in your practice, and are you seeing the results? Are you seeing the inflammation go down, the tissue return to a healthier stage of pink, baby pink, and firm to the tooth? So let's see in the chat, anybody getting in there? Hello, Heidi, message back. And Doc, in your practices, I'd love you to interject, of the practices that you're working with, what adjuncts do you see that they're using, before you come in and start suggesting laser?
So the airflow, I think air polishing, also referred to as guided biofilm therapy, that's a patented term, so I have to be careful when I use it. There is therapy, the powders have therapeutic effect. So when I designed the therapy with air polishing, laser, and then ozonated water, make it clear that it's aqueous ozone. I'm not using ozone gas. It seems a little redundant because they're all medicinal, but I think they're all additional. It just makes for a very complete therapeutic approach, right? And what's important to know is that there are SRP resistant bacteria. Some of those pathogens are actually in the tissue, and that there's a depth of kill with the laser. You're probably more of an expert than me, but I think it's called photoantisepsis, where it's
Photosepsis, yes.
yes. And so that's one of the key things that I try to explain to people, what the difference is. Why do I want to use a laser? Unfortunately, there's still some states in the United States that the hygienists can't use it, and that's just
Exactly.
it's shocking to me. I know that hopefully those things will get cleared up pretty quickly.
Yes, and so one of our next CE events that we're doing, again, free like tonight, is going to be helping you guys understand what is certification, what do you learn, and what should we be learning when we approach education for a diode laser, and then what is the difference between one state that is very regulated and allows hygiene to use it within the scope of their licensure, and then how is it prohibited and what activities are prohibited. So Kim Gifford says she's using microscopes, laser, water, air polisher. Beautiful, Kim. Excellent.
Yeah, that's the full deal right there. And that's just such a it's such a advanced approach.
And so I'll circle back to that point in just a moment, but I wanted to kind of play off of what you were saying, Doc, and how you decided to name this class, Lasers and Microscopes, the Perfect Marriage. So when I think of the perfect marriage, I think about support. How does each party, or in this case, each piece of technology, how do they support each other both diagnostically and therapeutically? So as you will learn, as you either continue education with us or otherwise, what type of bacteria is in the mouth? How aggressive is it? I don't think people really understand the pathogenicity of the oral microbiome and certain strains of bacteria. So if we could use that microscope and really pinpoint and use that as the centerpiece of the education, that's when you have a patient for life. How does it make you feel when your doctor takes the time to really explain to you what's going on in your body? And that's exactly what you're doing when you have a microscope in your toolkit. You're a glorified pathologist explaining to the patient what specific strains of bacteria they have and how that's going to have an impact both negatively and positively on their tissues and on their body. So how do these two technologies support each other? Number two, it's a long-term relationship. You're not going to invest in this technology if you're ready to sell your practice in the next year or two. These are usually doctors that are maybe 10, 12 years in their practice. They've gone through an associateship. They've already been through the ringer of, HMO, DMO, state-related insurances, and these are people buying technology that are ready to invest in their patients and in their practice and in their team. Usually these types of technologies do come with a team training component, and that really brings the team together. As you learn together, you grow together.
Right.
So it takes a team effort to create that long-term relationship with the patient. And so why I'm such a big proponent of operationalizing it is because people want the verbiage. People want to understand how to express what they're seeing on that microscope. They want to understand, how do I explain what's going on, with that laser light in that tissue? Like, what is it doing to actually work to heal the body? So those are the types of conversations. And we're not talking about having a very scientific and sophisticated, high level conversation about mechanisms of action and how the technology works. We're talking about taking the time to explain to the patients, why do your gums bleed? And what kind of bacteria is causing that bleeding? And what tools, treatments, and modalities do I have to
Yeah.
take care of that? And so that is what I found builds the long-term relationship. And I had a couple of notes that didn't quite make it in this slide deck, but to this degree, when we talk about sharing common goals, the common goal is to treat the disease on a bacterial level. And I want you guys to kind of make some notes as to why the technology is not being utilized. And as you saw, people come in with very, very valid concerns and questions about the technology. But think about, what is the opportunity cost for not using it? People are already coming into practices asking for laser. Do you use laser? Do you have laser? I don't want to take another medication. They gave me a medication last time, but it didn't work. It made my gums itchy and more. And I'm not going to foo-foo on any one specific type of medicament, okay? But we do understand the history of penicillin, and we know that this bacteria is highly resistant and it's very sophisticated. So it's really important that we understand how to identify it, how to stay ahead of it, and how to understand how the laser becomes a medicine to that treatment. So opportunity cost is real. Number two, fear of rejection. So a lot of us are afraid that our patients are not going to want this treatment based on cost. I've heard a lot about, I've heard this before in clinical practice. Elaine, you are traumatizing the team with your treatment plans because I'm prescribing SRPs, I'm prescribing laser, I'm prescribing the additional therapeutic medicaments, and of course, some of it is out of pocket. And the front office in one case was afraid to present the treatment plan. Can you imagine spending all that time using the microscope, talking about the benefits of the laser, educating the patient on what periodontal disease is, only for your front office to not present the treatment plan based on fear that they will not accept, will think we are pushing, promoting, selling them, and scare them out of the practice. Okay.
Yeah.
That's a valid. Do you have something to add to that, Doc?
Oh, and that's why this is I train, when I train the entire office. Okay. So I don't
Yeah.
just, the entire office is present because they need to understand everything that I'm communicating. If there's not a buy-in, if you have one broken link in that chain, which you just said, it sabotages the entire thing. So you're the practice owner, you're the dentist, and you're not understanding why this isn't, going smoothly. It could be one person who's not, doesn't have a buy-in. That's where the concept of buy-in is really important. And teams, and we've talked about that offline before. And developing your team takes patience. This is not an overnight, this shift to the wellness model. It's not overnight. You just don't flick your hand and say, I got that team, Dr. Riley, it took her years to get to her team to get to where now she has this team and a wait list practice. That did not happen overnight.
Exactly. And so I see a question of when is the best time to use the laser after scaling and root planing? Is there a time constraint with scheduling? Not when you operationalize it, not when you have a consistent workflow in place. So in terms of the handoff between the back office to the front, the treatment planning happens in the back and the buy-in happens in the back. So simply the front office is just relaying the financial side of things. So in our practice, I think in the best practice, the patient is already bought in clinically, therapeutically, and mentally, psychologically. They're already bought into these treatments because we have already shown them the slide. We've already shown them their pH testing or their salivary testing. We've already shown them the inflammation. We've shown them their IO photos. So the best time to use now the laser is going to be before and after. So if you take a laser certification course with us, we talk about utilizing the top 2 laser treatments, which are laser bacterial reduction, or better referred to as laser biostimulation, and laser sulcular debridement. So it's where we clean and cauterize the tissue to remove any infectious buildup of granulomatous material that builds up in the pocket when there is infection. So it's more of a cautery effect, a non-surgical cautery, okay? Emphasis on non-surgical. And it is a non-ablative photobiomodulative or biostimulation treatment. So if you guys sign in, I will send you guys more detailed slides and some research that you guys can access to just kind of get your juices flowing on the education front. So when is the best time to use the laser? It's in a protocoled appointment where you use it before and at the beginning and at the end of the appointment. So that is a great question. And then I want to kind of make a note on what does it mean to operationalize it? So this means that when you bring your patients into a appointment, you want to make sure that you have a workflow down. How do you seat them? How do you greet them? What questions are you asking them about their medical history? How are you identifying key references, such as their compromisation? Are they medically compromised? What systemic conditions do they have that are causing them to have a heightened response to oral bacteria and heightened inflammatory response? Next thing we want to see is what is their periodontal risk. A lot of patients already have a past history of probing. Most times in a general practice, the probing is incomplete. So I'm a periodontal hygienist. I work in a specialty practice, and we spend about 25 to 30 minutes just measuring the tissue. It's brutal. It's not fun. It's not fun for me. It's not fun for the patient, but we go through all the proper assessments of pocket depths, recession, mobility, furcation, everything we were taught in school, but we simply in the real world, in a general setting, do not have the time to do. So operationalizing it means we have an assistant there to help support a comprehensive probing at least 1 time a year. And that's by law, right? That's by our dental board standards. So bringing them in for a comprehensive review, making sure we're going through the medical history, also identifying key medications that are stimulating microbial growth in the mouth. So when Dr. Larkin talked about the oral systemic conversation, please attend his course. Please attend his workshops because he goes much more granular and in depth about these conversations. So, I'll tell you, this is how you buy that patient in, not by saying, oh, look at my fancy microscope and look at these bugs on the slide. No, it's the way you communicate to that patient and help them understand with these thorough assessments, these risk and stress assessments. Another one I want to talk about is the diagnostics that we're using. What diagnostics are you guys using in your practice now? I asked you what therapeutics and what adjunctive medicaments are you using, but what diagnostics do you have in your practice now? And that would be a conversation of operationalizing it. So if I have a office and I have 5 co-hygienists in this practice, are we all screening and grading the patient on level of tartar, level of bleeding, level of inflammation in the tissue? Okay. Are we all screening them and comfortable with uh, taking them from prophy to actual periostatus? Because that is the conversation that a lot of hygienists struggle with. They're scared to pull the trigger on perio. And this is why I love microscopes, because it softens that conversation. It's very subjective, objective. It's not like, hey, I have this new laser and it costs an extra, 50, 60, $100 per quadrant. And yeah, let's go ahead and use it on you today. It's like, no, hold the phone. Let's kind of take it a step back. Let's operationalize it. Let's go through vitals, medical history review, conversation on susceptibility, symptomology, etiology. Now I have a slide to show you what bacteria is driving this infection. And now let's talk about the solutions, or what we're going to do today to treat that. And again, it's required to operationalize it, because you don't want a patient to just do a one and done. I don't want my patients to have laser bacterial reduction one time a year. Okay. I want them to have it done every single time. And that takes operations. Okay. So hope I didn't go off on a tangent. And again, my slide deck will have all these little ticky-tacky suggestions for you. So as you can see, I'm greatly encouraging you guys to sign in and get my slides. And I'd love to hear from you, Doc, what your thoughts are on that.
Yeah, so I agree so much on the concept that this becomes a standard of care, right? So you're not subjectively saying, well, this is a laser patient, this is not. No, if it's a perio patient, the laser is incorporated into your protocols, right? So it's the same as the air polishing and anything that you can do collectively, and additionally is all beneficial to the patient. It's just your gums can't bleed. Okay. And one other thing that this is very topical. So I have a podcast with Dr. Bale this afternoon, and he re-emphasized something. This is really important because Dr. Bale is massively smart, 30 years experience. He said 50% of the risk factors in cardiovascular disease, in his opinion, are from the mouth. So, now whether it's 40, 60 or whatever, that's a huge number. Okay. That's a huge number. And so don't underestimate what we're really doing for the patients. It's a big deal.
And to that, Doc, can you talk to us a little bit about, so I'm a big proponent of the win-win-win model. I know exactly how much time, effort, energy it takes to go out and even take a laser course and learn and go back and change my habits, change my routines and processes in my clinical ops so that I can accommodate the technology. I want to say everybody go out and buy a laser right now, but I'm going to tell you, I really don't want you to. I want you to think about, where are the gaps in your standards of care right now? Where are the inconsistencies in the hygiene team? Are we comfortable discussing perio? Are we comfortable diagnosing? If I diagnose an SRP case based on generalized 4 millimeter pockets and generalized greater than 30% bone loss, is my doctor going to be on board with blessing that treatment? Is my co-hygienist going to be comfortable treating such an early, I don't even want to say early case, because I said greater than 50% bone loss, when really it should be 30% in my case. And so this is why it's so important to just start with aligning on your perio diagnosis, and how comfortable are you at having the oral microbiome conversation. And then think about bringing in, more technology to, support that treatment. So I want you guys to think about the clinical time you're taking now, going through your medical history, having these types of conversations, because it is very crucial that the patient understands the oral systemic connection between why their tissues inflame and how bacteria drives that. Secondly, your your patient's time. I mean, they they are our clients, and we should be seeing ourselves as a clinical consultant to them. We should, if we do not have a heart to serve our patients, then I don't know if the technology is for you. We are in servitude to those patients to help them understand why they're sickly or not. And so it takes time to have those conversations, and it takes patience, and it takes compassion. So I would say see where you are with, and when I'm stressed for time and I hate my assistant and they hate me, like we're not going to be in peace and harmony to be able to even do these, this level of, have this level of care for the patient. So it's really important that we kind of get on the same page with the team so that we can have a stable foundation for this. And then cost. If we're barely struggling to meet our daily production goal, if you don't even know what your daily production goal is, you might not be ready to ask the doctor to buy you a new 5, 10, 15, $20,000 laser. And that's a big statement, because we didn't go to hygiene school to learn the business of hygiene. So just kind of circling back to what you said, Doc, about the business of hygiene. It is a business. And the sooner we see ourselves as a clinical consultant and serving the patient, I think the quicker we'll be able to really embrace the technology, and be ready to kind of get it on board. And so the win-win-win would actually mean that the patient is getting the highest level of medical technology available and the best treatment available on a holistic level. There's nothing in this program that's talking about pharmacoagents,
Right.
chemotherapeutics. Okay, we're talking natural
Yeah.
therapeutics, and the patients want that. More and more patients want that and are seeking
Absolutely.
non-medical, non-medicine based.
Yeah.
Did you have something to add to that, Doc?
No, I couldn't put it better. Perfect.
So, and then the win for the patients, the win for the hygienist, if you are using laser on a routine basis, you very well deserve to be top paid. And this is why my company started focusing on operationals and operations and scalability with laser, because we want everybody cohesive and consistent. We want everybody speaking the same language, using the same protocols. And when that happens, the numbers most definitely follow. Our people who take our course, even with just a 1 day training, are going back to their practice and implementing right away, and are starting to produce two, three, $400 worth of laser services. And that's nothing to scoff at when you're looking at each patient and the lifetime value of that patient, who in today's world, we can expect that patients will be our patient and stay with us and loyal to us for maybe a span of 3 to 5 years. Back in the day, Doc, what was your longest patient in your practice?
Yeah. Long, forever. They stay forever.
Years,
Yeah.
decades, right? We see these kids grow, we see them get married, have babies. It's beautiful. So nowadays, imagine that perio patient who's coming in 4 times a year times 5 years that they're with you, and they're paying X amount per treatment each time they come in. Now times that number by 1,500, which is the based on just basic, basic math. Uh, each doctor, single doctor practice probably has about roughly 1,500 active patients. So I want to help you guys look at the potential ROI and investment in this, not in today's clinic, of course, or today's webinar, but in a future webinar, because I want you guys to be able to understand the financial value to this, and how lasers and this microscope technology will only enhance the value of your practice, as well as you as a clinician, and be able to earn top dollar for what you do. Okay. And then the last thing I say to that is, the overarching goal, which is to be able to um, maybe one day sell your practice. And so, Doc, can you go back and speak about the doctor you mentioned in the beginning, how they started with microscopes, and you gradually helped them bring in the technology, and then what did that do for their EBITDA, and what did that do for their
So,
end goal
yeah,
and
so let
value?
me talk about KPIs, because there was a study done by, it was one of the founders of Dental Intel, And it was a pretty comprehensive study on hygiene engagement and then overall production in the practice. So when I talk about a creation of value, what I'm saying fundamentally is this. Let's say Mrs. Smith is an insulin-dependent diabetic, and she comes in and goes through this process of salivary diagnostics, and that she understands as a part of her ongoing therapy, it includes a laser and includes air polishing or whatever.
Mhm.
She knows that she's engaged in my practice to support her health. Okay. And hopefully I have a relationship with her physician. So the numbers are this: 60% of a KPI in the difference between 60 and 90. Okay. 90% is kind of a goal in, pre-appointing, getting people engaged. 60% might be a little bit above average, but the difference in those two numbers was on the clinical production side is double. Okay. That's a really, really, when I say that hygiene drives restorative, there's your answer. So how do you get from the 60 to the 90? It's the creation of the value of, oh, my cleaning appointment has an entirely new purpose. This is about my health. So if it's a nice spring day and I want to go play golf, I don't cancel on a whim like I used to. Okay. This appointment is important. Okay. So that's really the ultimate goal here, is getting hygiene where it needs to be in the healthcare, in our screwed up healthcare system, which is now moving toward a preventive model. You're going to hear in the next 2 years, you're going to hear nothing but prevention and proactive care, because that's the solution on the medical and dental side for a system that's just breaking down before our eyes.
Mhm. Thank you, Doc. I had a question on what type of certification do you need to use the laser? I'll put in the chat the curriculum guideline standards of laser education. So it's the course curriculum for what a certification course covers, and that is what's necessary. And some people have dwindled it down to X amount of hours of online self-study where you watch all these videos by yourself and then come into a very crowded hands-on event that only lasts for a couple of hours and you're like sharing lasers. So a really thorough, great hands-on certification course will be at least 1 day. I mean, I'm telling you, the courses I've attended at the World Clinical Laser Institute were like 3 days long, 12 hours a day. So it's a lot to learn. Okay. Our course is always minimum of 8 hours of live education, and our webinars are minimum of 12 hours of live education. And it will test your stamina, boy. It really will. So I'll link that in the chat, and I will also I'll just put it, I don't want to waste your all's time, so I will put it in the post email that goes out. So thank you, anonymous attendee, for asking that question, what is certification? And we will be hosting another webinar to help you understand that as well. So do you have any final thoughts, Dr. Larkin?
I think that, this was fabulous. Congratulations on putting this together. I'm very grateful for you for doing it, because I think it was a lovely explanation, because I think there's things that people need to understand the why. Why do I want to do this, and how do I do it? And you did a great job.
Thanks, Doc. You did too, as always. And also, I'm hoping that we can get the link to your podcast episode with Dr. Bale that we can also attach to the post-course thank you, because people get so much value. And Doc, tell us tell us about your upcoming events, please. And please tell us about your podcast and where we can find
Yeah.
you.
So I launched a podcast in January because I really want people to meet these amazing people in my world. And it's called Oral Systemic Connections plural. And it's about interviewing, and I'm telling you, I've done 4 episodes, and it's good. And I'm biased. But to do Dr. Bale today was just a tremendous treat, because I'm such a fan of his. So it's on Spotify, iTunes, YouTube, Oral Systemic Connections. And I think what it's going to do, it's going to index my world, meaning, all of the, and someday, Elaine, you're going to be on there. You're going to be on the index of the laser expert, right? And so So I can refer to that channel and say, you know, if you want to know more about this, here's ozone, here's laser, here's this, and meet the people behind it. The thing that is driving podcasts today as almost a preferred method of obtaining information is the personalization, where you get to kind of evaluate the people behind the scenes. You get to,
Yeah.
it's a little more informal. You know, it's not a webinar, but it's kind of like, hey, tell me how you grew up. Why did you want to become a hygienist? Whatever. I love it. Okay. So that's, and so then my course in April is a 1 day course. It's a little bit of a pivot, and it's called the Blueprint. And I did this intentionally, and Dr. Bale is the keynote. And because the number one question that I get is, how do I start to make this pivot? And so I'm bringing in all these incredible experts, and we're going to create a blueprint of what that looks like. And then in September is my quote unquote normal course. And this is a course that I created about 5 years ago, which is very novel and it's very different. And so it's a 1 day lecture at a hotel. And then the second day, it's a breakout session clinically, where it's a full exposure to all of these technologies. And the reason why I designed this course this way was because this is the way I would like to learn. So we break into small groups clinically, and you get to put a laser in your hand and play with it for a half an hour in a small group. And then you move to the next station and you get to do a microscope slide and see what that looks like. And then on down the line. And so all of these technologies, but it's hands-on. And it's a really, really popular course. And I'm excited to get you involved in that. You got to attend last year, and it's,
I
you know,
did. It was
it's,
transformational.
yeah, yeah. And so what it is for the owner dentist, the objective is, I want you to come in. There's no pressure. Just take a look. Some of this maybe the laser makes sense and nothing else. But what has happened is that there are people that came and they got engaged in everything, right? So my wheelhouse is the microscope, and then they hired you for the laser training, and then, you know, air polishing is over here, and
Mhm.
it's everything. And that's why it's called oral systemic mastery, the future of hygiene, because I wanted to create that definition. And I think I'm lucky enough that I did.
There's nothing like it. I'm telling you, it's like the biggest, most beautiful office you will ever see. Every room has a subject matter expert in the room. And the one that really resonated with me, of course, the laser room, but the carotid artery
Yeah,
scanning.
yeah,
Imagine bringing carotid artery scanning into the practice.
yep,
And actually maybe charging a little fee for it, because I would pay for that.
yeah,
I would want my parents to pay for that, my dad who's
right,
aging, my grandparents. So
right,
these are screenings that patients wouldn't, it's the concept of bringing technology into a general dental practice and crossing that bridge of expanding into the medical technology side and making everyday screenings accessible and available to patients who may not otherwise. And I think that's why I'm so passionate about what I do as a clinician, albeit I am a mid-level provider. I am not the doctor and I'm not the owner of the practice, but I am that bridge to the patient's understanding of wellness and healing. So I'm very, very excited to be a part of this, because you're bridging that gap, bringing in new technology that you can put in my hands to help me feel like I'm making a better impact as a hygienist. I'm not just the tooth scraper. So thank you, Doc, for everything you do to help bring that to us, and all the respect you have for hygienists and how you help elevate us. So thanks a lot. I really appreciate you.
my honor. It's my honor. Thank
Thank
you.
you, everybody, for joining tonight. I hope you guys are still in the end. I don't even know how many people are here still. So if you're still here in the end, I would love to see a thank you. And then I'll also be looking out for your emails in our checkout. So thanks, guys. And if you have any other questions, feel free to type them in and we will answer them. We'll be hanging out here for the next couple of minutes, seeing if as you guys either trickle off or stay on. I know it's kind of late in the East Coast.
Lots of nice thank yous. I appreciate that. Wow, everybody's, yeah, very nice.
Still a lot of people here. That's awesome. And by the way, have we been on for 2 hours, Doc, or how long has it been?
Yeah,
An hour and a half or two?
hour and a half.
Hour and a half. Okay, good. We stayed on point then. So we'll be getting 1.5 CEs. Thank you, Jose. Thank you, Ishmael. Thank you, Kim. Thank you, Heidi, Carla, Helen. Thank you guys all for joining us. Oh, we have Jennifer Moran. Thank you, Jennifer. Awesome. Excited about the podcast. Excellent. All right. Let's see. And show here.
Go.
Oh, I see. Okay. Okay. We have about 31 people here still. Great. Thank you guys. Thanks, Anna. And Doc, so in your upcoming class now, the one that you have here in April very soon, tell us about some of the speakers that you're having from abroad and some of the things that they're doing
Yeah.
that sparked your attention.
So it's going to be kind of a TED Talk style. So it's going to be, a lot of speakers, but a half an hour. And Victoria Sampson is coming from London. She started, and once again, I just meet these random people from around the world, and I
Mhm.
just, hey, I want to meet you. Come to Lexington. She started a practice called the Health Society, and she also started her own salivary test, which I don't know anything about, but I'm going to learn about it. And she's like 30 years old, and she had a podcast that had 1 million views. And I'm like, okay, I need to talk to you. What are you doing? Anything that elevates this conversation is going to get my attention.
Mhm.
So she's coming. Dr. Bale's the keynote. Dr. Bax, who's my Bale Donine physician. I've got a couple of PhDs. Dr. Stein's going to go over prebiotics. And then this Dr. Blumenberg is going to go over another area that's got my attention. And I realized that I spend a lot of time on perio, but we need to talk about caries too. So we're going to
Mhm.
talk about biorestoratives and AI and Pearl and looking at early carious lesions and regenerating them and fixing them with he's got a product similar to Curadot called
Okay.
Crystal Care. So
Amazing.
you're going to be speaking. Let's see, I'm going to see if I can remember everybody. Oh, a couple different people on testing, and then Rachel Riley, who has the holistic practice here, is going to go over her onboarding. What does a new appointment look like?
That's
And
great.
then she's going to go over protocols like smart. I asked her to go over SMART, Bredesen. What do those look like? So what's different about this course is I'm not going to have a handout as to what this course is going to be. The handout will be afterward. It'll be created
Mhm.
from the course, what we've learned from these 10 or 12 individuals.
Beautiful.
There's a company called from Korea that's coming called AO Bio. I hope I say it right. They have a camera. It's a digital disclosing. It's a camera that you take a picture of the mouth and it discloses the biofilm with photo, whatever, bioluminescence or whatever the word
Mhm.
is.
Mhm.
And they have all
Bioluminescence.
these cameras. Yeah. And
Amazing.
that's kind of cool. So I'm just looking for things in hygiene. Number one, that's going to make our life easier. Obviously, there's a lot of stuff happening in AI. You were
Mhm.
talking about your charting and stuff, and I'm going to talk on that and touch on Pearl.
Mhm.
That's going to change in the next 2 or 3 years. You are not going to be burdened with a lot of that cumbersome stuff.
Yeah.
From what I've been told, you're going to be able to take a scan and it'll actually scan periodontal pockets and everything.
Amazing.
Yeah.
I
So
love that you're on the cutting edge and the forefront of what's to
yeah,
come. And
yeah.
Doc, we had a question. Will there be a chance for the recording of the April day? So is there an opportunity for people to attend virtually?
I've reached out to somebody about a live stream and I haven't heard back yet, but
Okay.
I'll continue to kind of press that because I've got people coming from 4 countries and it would be great to be able to live stream that and plus the fact that it's such a unique collection of experts. I probably won't be able to duplicate that meeting again.
Yeah.
It's kind of happened organically. And then the other thing that's happened, which was totally unexpected and has a lot to do with some of the political stuff. There's a senator that's involved with that's in communication with the RFK about the changes in prevention. I think she's going to come. I mean, I invited her and I've been communicating with her
Wow.
because she's going to be at the end of the day one of the lawmakers. And if prevention becomes policy, see, this is what I'm kind of banking on. It's going to have to be, and it's going to
Yeah.
have to be funded by HHS some way, somehow. It won't be tomorrow, but that's why prevention, everything that we're doing right now, prevention is very timely. It's very,
Yeah. Yes, yes. And so that is the very essence of our collaboration is being able to get people access to these preventative modalities because welcome to America where you get sick and we just write you a prescription. You know, that was the first question I heard when I would talk to patients about, oh, you have gum disease. We need to do some treatment. Will I get an antibiotic with that? Are you going to write me a prescription for my infection? And I'm just like, no, no,
right.
no, 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 we're not doing that. So that is like why I got so passionate about laser because it is not a it's not a antibiotic. It
Right.
is not, another chemotherapeutic that's going to give you drug on drug interaction. It's only natural, medicinal, holistic
Yeah.
therapy.
And I'm really glad, I forgot to mention this. I'm very glad that you brought that up because one of the problems, and this goes back to kind of the inception, and I'm going to say, for lack of a better time frame, 10 or 15 years ago, where salivary testing kind of came about.
Yeah.
And what the companies were doing, and I was very much against this from the beginning, just kind of organically,
Yeah.
they would give you a test result and they would give you an antibiotic recommendation. Now, I learned how to do this without antibiotics. I think it's overkill. And where it has really become unpopular is in the functional medicine space and learning more from physicians, the effects of antibiotics on the gut health. It's significant. It can take you,
Yeah.
metronidazole, it's brutal. That's a brutal
Yeah.
antibiotic. And I never used it because I always thought it was overkill. That was just kind of my instinct. But now it's like it would take you 6 months to recover from that. So can we do something? And I love the term holistic in reference to the laser because it's not. And so what's happened, that has created a problem. The salivary diagnostics companies have created a problem because they linked test results with antibiotics. And the dentists are novices on all of this, right? So they go, oh, I'm going to try salivary test. And then they get this test and then they write a script and they think that that's the therapy. And that was a mistake. Okay. And I know the hygienist personally that actually changed the company Oral DNA so that they now on their form they have an antibiotic or diode laser therapy. And she was
Amazing.
responsible. She was the chief hygienist for Pacific Dental, and she put 1,300 lasers in across Pacific because Pacific is a very Steve Thorne is a very proactive health person,
Mhm.
right? And so I know her that she did that, and so yeah, really important. The antibiotic conversation is really important.
So great. So impactful.
Yeah.
So, well, I think we will wrap up with that. Thank you again, everybody who joined us this evening. This will be on with Dr. Larkin's materials. Dr. Larkin, what are your websites and your social media handles, please?
Okay, so POW Hygiene, POW Hygiene is one of my sites, and then Oral Systemic Mastery is where the course material are. And then
Okay, excellent.
yeah, so I've got a YouTube channel under Thomas Larkin and a little Instagram, but not much. So I'm now that I'm doing the podcast, now that I have, a lot of content and stuff, so I'm kind of building out.
Good, good. And so we will make sure you guys have those available. And I hope I'll see you guys back at our next study club event, which will be putting on our YouTube. We'll be putting on our socials at Dental Laser Integrations and at Laser Elaine. And we have Facebook, Dental Laser Integrations. And then you can always find us at dentallaserintegrations.com on our webinars tab. So we're pretty much everywhere. All right. Thanks, guys. Have a wonderful evening. And thanks again for being with us.
Thank you so much, Elaine. It was awesome.
Doc.